So next, I'm going to hand things off to Dr. Kristen Cooksey Stowers, who is an assistant professor in the Department of Allied Health Sciences and the Rudd Center for Food Policy and Health at the University of Connecticut. Dr. Cooksey Stowers will be moderating our next panel focused on integrating social drivers into PSE interventions. Thank you, Dr. Cooksey Stowers.
Thank you, Dan. I'm really excited for a robust conversation in this panel. I'm absolutely thrilled and honored to be serving as a moderator for this session and this excellent panel on integrating social drivers and PSE interventions. If I may take the liberty, I think as you will see next, the presenters will cover 3 excellent points. Overall, we've heard a lot about the Getting to Equity framework, the GTE framework, spearheaded and created by Dr. Shriki Kumanika, which we have heard a lot about yesterday and earlier today. And in this session, the presenters will cover actually all 4 quadrants of that framework, which is really exciting. Increasing healthy options by covering neighborhood-built environments and transportation, reducing deterrence by way of important topics such as gentrification and residential displacement, improving social and economic resources via food insecurity and housing status, plus building community capacity, the 4th quadrant, particularly leveraging CBPR, community-based methods, and promoting health behaviors. So for today's session, we have presenters including Dr. Ashlesha Datar from the University of Southern California, Dr. Jennifer D. Roberts from the University of Maryland School of Public Health, and Dr. Hilary Seligman from the University of California, San Francisco School of Medicine. So I'm excited to pass it first to Dr. Datar.
Thank you so much, Kristen. Can everyone hear me clearly? Yes. Thank you so much. Hi, everyone. I just want to start by thanking NCORE and the organizers for inviting me to participate in this workshop. It's been great listening to all the speakers and panelists, and I'm really excited to share some of my work in this area. Kristen, introduced me a little, but I'll just add briefly that I'm an economist by training, but I've spent most of my career studying social determinants of obesity in children and families. But more recently, I've been involved in studying housing as an integral part of community interventions and how that influences obesity. And so in today's presentation, I'm going to share some of my work in this area and reflect upon a few things. Next slide, please. Oh, and I have no disclosures to make. Next slide. Okay, so PSE interventions have primarily focused on either food-related PSEs or physical activity-related PSEs, and children have focused on particular settings such as schools, childcare settings, and at home involving parents. But there's very little focus on the role of housing. But there's both growing evidence and interest in understanding the link between housing and health. Much of the existing research in this area has focused on housing quality and has looked at the effects of environmental toxins such as lead, asbestos, or pests and mold on a variety of physical and mental health conditions, but there isn't much looking at the effects on obesity and related behaviors. There's also recent work coming out of the very cool linkages between HUD data and the NHANES that has looked at housing assistance in health, including cardiometabolic risk, and suggests some protective effects, but this has been mostly among adults. And then there are some relatively newer areas of research where there is more needed. For example, there's a very interesting literature looking at building design features in multifamily housing and how active design principles, for example, can be used to encourage physical activity. And in addition, even like the income mix of residents in a building may also influence obesity-related behaviors through social pathways. So some interesting new lines of research being pursued within the housing literature, and it's really exciting to see that housing is coming more and more part of the conversation of PSE interventions. But today I want to focus on public housing in the US, which I think provides important lessons and opportunities for studying housing's role in addressing obesity in low-income populations. Now, it's well known that public housing communities in the US have been synonymous with poor quality housing, high poverty, and very high crime. And so not surprisingly, overweight and obesity rates in these settings have been very high. Just by way of some history, in the 1990s and early 2000s, large federal programs tried to address this concentrated poverty and poor housing conditions by giving out grants to public housing authorities across the country to demolish and redevelop these sites. And these redevelopments used to be limited to rebuilding the public housing sites into mixed income communities. But that approach was eventually abandoned due to concerns about gentrification and large-scale displacement of residents. So now the focus is on revitalizing not only the public housing site itself, but also the neighborhood around it, and making comprehensive investments in social determinants of health while making efforts to keep residents in place. And so as the stock of public housing in the US is rapidly aging, this creates valuable opportunities to study how rebuilding these communities and their surrounding neighborhoods can simultaneously intervene on multiple key social drivers and impact obesity. And that's where some of the work I'm doing comes in. Next slide, please. So we have a couple of studies funded by NCI and ICHD underway in Los Angeles, California, where two major public housing redevelopments are underway. The first is the Jordan Downs public housing redevelopment in the Watts neighborhood in Los Angeles, which began in 2018 and is nearly halfway complete. And the other is the Rancho San Pedro public housing redevelopment near the Port of Los Angeles, which is still in the planning phases. And these grants are evaluating impacts of these redevelopments on obesity. But for today's talk, I'm going to focus on the Jordan Downs redevelopment, which is further along. So by way of context, Jordan Downs is a 50-acre site in the Watts neighborhood in South Central LA, housing mostly Hispanic and Black residents. It has about 700 housing units. And like most other public housing sites in the country, it has significant structural problems. There's mold, pest, water quality issues, overcrowding, etc. And it wasn't worth repairing anymore, so it was slated for a complete teardown and rebuild. But the interesting part about this redevelopment is that the site was chosen in large part due to availability of a 20-acre vacant parcel of land right next to it. So this allowed for a build-first approach where new homes could be built on the new land, and then residents would move into these new homes, and then their old homes would be demolished, and this cycle would continue in phases until the whole now 70-acre site is redeveloped. So this meant that there was no need for resident displacement, which is a very important and novel feature of this redevelopment. The redevelopment itself is pretty comprehensive. It is building brand new housing that meets modern building standards. So again, improvements in water, tap waters and the piping and plumbing and just the quality of the homes overall. The extra land that's been taken in to make this redevelopment allows for a doubling of the housing capacity, which means an influx of mixed income residents into the community. So that's likely to change the social environment. And then there are major improvements to the built environment, which includes addition of a supermarket and retail. There's parks and green spaces, community spaces, bikeable, walkable, tree-lined streets, farmers markets, community gardens, safety features. I can go on and on. And then finally, there are economic opportunities in the form of jobs with preference for local hires and training for job skills. So it's a very comprehensive sort of whole of community intervention. So to evaluate the effects of this redevelopment on obesity among residents, we began the Watts Neighborhood Health Study in 2018. And the study has several features. It's a natural experiment in that it exploits the plausibly exogenous variation in residents' exposure to the redevelopment created by this phased build-out to study its effects on obesity. We recruited a cohort of over 800 adults and over 700 children from Jordan Downs and from 2 comparison public housing sites in Watts. And we did annual surveys and assessments to collect data on anthropometrics, which included height, weight, waistline, and body fat percentage, as well as diet and activity behaviors and a range of obesity-related risk factors. We were also very intentional about collecting data on a broad set of social determinants, including what's happening to crime, social cohesion, what are people's tastes and preferences, cultural factors, and perceptions of the neighborhood, to name a few. And so far, we've collected up to 2 rounds of baseline data and 2 years of follow-up data. The analyses are underway and under review, several papers. So unfortunately, I can't share the main findings thus far. When there's an Opus 3, I'd be happy to present them there. But I do want to share some broad insights from this work. Next slide, please. But before I do that, I want to show you what our study participants look like for context. Our adults, so this is again an entire family. So our adult sample is primarily female, average age in the early 40s, 62% Hispanic, and the remaining Black, and with very low levels of education and household income. And the child sample includes children all the way from ages 2 to 17, with average age about 10 years. It's 52% female and about 70% Hispanic. And the pie charts show the rates of overweight and obesity at baseline. So about 81% have overweight or obesity among adults and 52% among children. So this is a very high risk community, as you can see. Next slide, please. So with that background, I want to share some reflections based on our findings thus far, at least the ones I can share. The first is that participants had many different barriers to eating healthy and exercising. And this is, I think, important. It sounds simple, but it's important because low-income minority communities are often characterized as having a homogeneous set of constraints. Like the most common one that you hear, they're all food deserts or they're food swamps. But what we find is that there are a range of different barriers. Not surprisingly, on the left, you'll see that the most common barrier to healthy eating was cost. But surprisingly, lack of healthy food store access was the least commonly cited barrier, at least in this community. Instead, there were other things like healthy foods don't taste good, or cooking's a chore, or lack of cooking skills that were cited more often. And then on the right is the barriers of physical activity, and you'll see that safety and lack of opportunities were most commonly cited, although there were several other things such as lack of time, don't have company, health concerns that were also common barriers. So what this suggests to me is that if the barriers are varied, then the solutions need to be varied too. Next slide, please. Second, we also saw that residents reported multiple barriers to healthy lifestyle. So this chart shows the percentage of participants who reported different numbers of barriers. Interestingly, a sizable proportion reported no barrier, which we clearly need to unpack a little bit more. That was a little surprising. But nearly half reported 2 or more barriers to physical activity, and a third reported 2 or more barriers to healthy eating. And in fact, 44% had at least one physical activity and at least one healthy eating barrier. So again, this suggests that solutions need to be comprehensive because all or most of an individual's barriers would need to be addressed in order to lead to sustained behavior change. Next slide, please. And so some additional reflections are listed here. One major challenge is that comprehensive PSE interventions, such as ones involving major improvements to housing conditions, will take a long time to implement and even longer to realize their full potential. In the case of public housing redevelopments, there's a long period of planning followed by financing, permitting processes, the demolition, the construction of the buildings, and then full occupancy. The planning process itself took a decade in the case of Jordan Downs, and the build out will take another decade. That's really long, and certainly not studyable within a typical NIH grant timeline. So that little survey that we did at the beginning, it hits home really well for me that this is really challenging. There's also significant mistrust of research in these communities due to a long history of structural racism. And so it takes a significant amount of time to build the community partnerships and trust needed to study these redevelopments. We often got this, we often heard what's going to come out of this for me? You guys, researchers just come into our community and want to study us, but why? And it's a really valid question. So I think it takes time to build that trust and partnership and get people on board. And that is a challenge and something we need to work on. A second challenge, or rather observation, is that because this process is so long, there is inherent short-term instability in the neighborhood that can have unintended consequences. For example, in Jordan Downs, there's a significant difference in social disorder, cleanliness, and upkeep of areas that are redeveloped and those that are waiting to be redeveloped, which creates this dichotomy in the community that can lead to uneven benefits. And that's some of the things we're trying to demonstrate in some of the papers that are under review, that this is a really, and it takes a long time. So there's this sort of instability that really needs to be, factored in. Another observation is that even though this redevelopment was designed to avoid involuntary displacement of residents, there is voluntary displacement. Around 22% of original Jordan Downs households have opted to relocate outside Jordan Downs, and it's unclear why, although some of it could be due to the timeline for this build out is so far, and people are like, I don't know if I'm going to be around to see this. And also maybe the short-term disability, maybe the people who are living in the areas that are not yet redeveloped are kind of declining more before they get better. And so, or it's just skepticism overall. I mean, we've done surveys to ask them, like, why did you choose to leave Jordan Downs and move somewhere else? And they often say better neighborhood or better schools or better, but, which is a little surprising because the point of this redevelopment was to really change a lot of things for them. So there's some things that we need to unpack here. But that said, these redevelopments, I think, provide an invaluable opportunity to study how whole of community interventions can address obesity. And then by studying different redevelopments, we can sort of understand better how context matters. And then when we can compare them to understand sort of what the secret sauce is that makes such efforts improve health. And I think I'm almost out of time, so I'm going to end here with my last slide, please. I'll just leave you with some pictures of the original and the newly redeveloped areas of Jordan Downs. There's a lot more about the study on our website, which is provided below, and my contact information as well. And thank you so much.
Hello, everyone. Hopefully you can hear me. I am going to begin and I'm going to talk about the GENTS study, which I've been working on for the past few years. Next slide, please. I have no disclosures to declare. Next slide. So I actually want to begin kind of framing the whole issue of physical inactivity and just really how as a nation we've become less active throughout the decades. And specifically regarding children, we've significantly seen a decline in their active transit to school. From roughly 1969 to 2009, there was about a 35% reduction in the percentage of children who actually walked or biked to school. And I saw some most recent details or data showing that in 2017 that actually reduced to about 10.5%. So it was about 13% in 2009, and then it went to about 10.5% in 2017. Next slide, please. So why does active transit matter? Well, it matters because, people who engage in some form of human-powered active transportation are more likely to be physically active and really achieve a healthy or maintain a healthy weight. And so this includes public transportation, such as taking the bus or even light rail transit. Next slide, please. Next slide, please. So in the Washington, D.C. area, we have what is coming in the next couple of years, or it may be a little bit longer, the Purple Line. And this has been a project that has been coming for a very long time. As you can see in this article from the Washington Post in 2017, where I was initially interviewed about this study, we have had significant delays going on, but we've finally broke ground. And so it is coming. It's just a matter of when it will actually start. But it will actually be a light rail transit. Next slide, please. So one of the issues, before I get into the study, I want to talk about one of the issues that actually was alluded to with our last presenter, and that is actually transit-induced gentrification. And so we see that phenomenon quite a bit with actually light rail transit. It's really defined as a phenomenon whereby the provision of transit service, particularly light rail transit, and the associated development, so the transit-oriented development, kind of change the direction of the neighborhood and kind of a sort of quote-unquote upscaling. And it really is just a socioeconomic byproduct and an unintended consequence. And this can come in many forms. So you could have everything from actual residential displacement, business displacement, to something that is actually just cultural displacement. And there has been some research that's looked at overall gentrification with some health consequences, such as higher cancer rates or cardiovascular disease. But a lot of that research has come after the fact or after the gentrification has actually taken place. Next slide, please. So let's take a look at this Washington metropolitan area, the transit system. So this is the existing transit system. This is the heavy rail system. And so here we have over like 100 miles of track that covers the district, areas of Maryland, as well as Northern Virginia. And there's a total of 6 heavy rail lines. Next slide, please. And so with the purple line, which is actually going to be a light rail line, as I had mentioned, it will be an east-west line that will extend from Montgomery County to Prince George's County. There'll be a total of about 21 stations, and 11 of those stations will actually be in Prince George's County. And that's going to be the actual area where I'm going to be doing, where I am doing the research for the GENTS study. In that area, the reason why I'm doing that is because that area is about 80% African American and Latinx, and it has a significantly lower per capita income in comparison to Montgomery County. Next slide, please. Next slide. So this GENTS study, which stands for Gauging the Effects of Neighborhood Trends on Sickness, it's actually going to examine perceptions of transit-induced gentrification, or what I'm referring to as TIG, among the Prince George's County residents. Next slide. Before I get into the study, I want to talk about some of the methodological considerations, specifically when we're looking at issues of the participants in Prince George's County. There's an exceptionally large Latinx population, and so language was a consideration, as well as the project literacy, meaning that a lot of people didn't really know what the purple line was. They didn't know when it was coming, which is really an issue in some of the communication that has been extended out to the constituents of those areas. But this was actually very easily handled with, language translation and information that was provided about the purple line. But one of the bigger issues was distrust, as was mentioned by the previous presenter. Initially, I tried to hold focus groups to get people's their kind of attitudes and their opinions on the purple line, but I had a difficult time recruiting participants. So we actually decided to just actually go into the community and literally go and interview participants at the transit stops. And this greatly improved our the participation. Next slide, please. So this overall objective of this study is to evaluate transit-induced gentrification, or TIG, and associated health outcomes or drivers. The 2 drivers that we're looking at are walkability and crime, and the 2 health outcomes are heart health and anxiety. And so what I'm going to talk about specifically today is Wave 1, which was data that we collected in the spring of 2021. And I'm specifically going to talk about the perceived TIG in reference to heart health and anxiety. But before I get to that, I'm going to talk a little bit about the questionnaire. And also, I'm only going to talk about the quantitative data today, or the quantitative results. Next slide, please. So our GENTS study questionnaire was created using elements of pretty much established instruments. And one of those was the neighborhood change and gentrification scale, which I will discuss in a minute. But we had about 8 sections. And so we had questions that we asked people about themselves. We also used questions from the Kessler Psychological Distress Scale, NHANES, the Neighborhood Environment Walkability Survey. Next slide, please. So, for example, in the first section, we ask questions about people's relationship status. Next slide. For questions in the second part, this is the part where we get into the aspects of gentrification. We were asking people about fears of being pushed out of their neighborhood. Next slide. And these were actually taken from the neighborhood change and gentrification scale, as I had mentioned previously. This is a 10-item scale using a 5-point Likert response rating. And 5 of these items were developed, next slide, please, using census-based measures. And the other 6 were developed or drawn from already existing qualitative and quantitative self-reported research on experiences of gentrification. And you had questions or items such as, I felt increasingly out of place in my neighborhood, or I've seen a disruption in local community ties. There's a variety of elements in this 10-item scale. Next slide, please. So the next sections, and you can keep going to next slide, were basically about the purple line, about COVID, about stress and anxiety, next slide, about heart health, and questions about walking in your neighborhood, next slide, and also questions about crime in the neighborhood, next slide. So for wave 1, we had a sample of 465. We'd had a nearly doubling of women compared to men. About half of the respondents were never married. I was pleased that our race and ethnic proportions pretty much mirrored Prince George's County 2020 census, and the average age was 50 years, and about 60% of the respondents were homeowners. Next slide. We saw the largest proportion of people, they actually completed high school. However, over 50% had a degree higher than high school education. And also nearly half of the respondents had an annual household income under $60,000. Next slide. In terms of perceived TIG, all items of the 10-item scale, they were coded such that the higher scores indicated a greater sense of disruption or a gentrification as examined independently. But in our preliminary findings, we looked at perceived TIG and like race, for example. And what we found was very interesting was that more white residents in comparison to the residents of color felt out of place. Next slide. Also, more non-Hispanic residents observed changes to their, quote, sense of community in the neighborhood in comparison to Hispanic residents. And this was also statistically significant. Next slide. When we looked at heart health, we found a statistically significant association between perceived TIG and hypertension. So for example, residents taking prescribed hypertension medication in comparison to those who did not reported an influx or this kind of increase of affluent, quote unquote, non-minority residents into their neighborhood. Next slide. Additionally, residents diagnosed with congestive heart failure were twice as likely to fear being pushed out of their neighborhoods compared to those who did not have heart failure. Next slide. In terms of mental health, there was a statistically significant relationship that was found between perceived TIG and tension that almost showed like mirrored a dose-response relationship, whereby the residents who were experiencing more tension were more likely to report an influx of affluent or, quote, non-minority residents into their neighborhood, which is similar to the next slide, where we saw a more clear dose-response relationship between negative TIG perceptions and reported stress, reported stress and anxiety. So again, residents who experienced more stress were more likely to fear being pushed out of their neighborhood. Next slide. So based on these kind of preliminary findings, we can conclude that the TIG perceptions, they varied by race, ethnicity, by heart health status, and anxiety level. And I'd also want to note that to the best of my knowledge, this is the first study that's actually assessed gentrification during the construction period, which is really key. It's funny because it's a plus and a minus in the sense that one of the issues that Dr. Datar had mentioned previously was that this type of research it does not fall very nicely with NIH timelines, meaning I had applied for R1. I didn't get it, but actually in hindsight, it's very good because I had hoped to have, post purple line data, which is not the case. This was actually, the purple line was supposed to be in operation back in I believe 2017, and then it went to 2018. Now is The most recent I've heard is now 2028, even though a month or so ago I thought it was 2027. So it doesn't very much fall in line with the kind of grant timeline that you need to do like a very nice pre-post study. But in any case, it's allowed me more time to actually get pre-construction or pre-purple line data. And then the last thing I also wanted to mention is that hopefully, the GENTS study will actually be able to provide kind of more effective procedural solutions for not only Prince George's County, but other regions who are kind of at risk for this type of transit-oriented development-related gentrification. Next slide. I want to thank you for your attention. And I just want to acknowledge that the funding for this study has been supported by a JPB Environmental Health Fellowship that was operationalized through Harvard School of Public Health. Thank you.
Thank you, Dr. Roberts, and also thank you to Dr. Datar. My apologies, there were tech issues with the video. For those two excellent presentations on both the neighborhood health study, focused on public housing as a structural and social driver of obesity and obesity-related inequities, as well as the GENTS study from Dr. Roberts, who you just heard from now, which focused on the transit-induced gentrification as an important structural driver of heart health outcomes and stress and anxiety. Next, we will hear from Dr. Seligman from the University of California, San Francisco School of Medicine. Please, Dr. Seligman, good to see you, and take it away.
Thank you so much. So I have been tasked with integrating social drivers into childhood obesity research methods. Next slide, please. And I want, before I start, I would like to say that I received funding from many federal agencies and other places, but these opinions are my own. Next slide, please. In preparing for this presentation, actually, I'm glad, Dr. Cooksey Stowers, that you mentioned Shariki Kumanika, because she specifically asked me to share with you a study that actually has no specific childhood obesity outcomes, but that helps us maybe to think about how we can leverage data and patterns in data in new and different ways in order to try to answer new questions. And so what I'm going to present to you today is an example of a natural experiment that helped the field think a little bit differently about a question. And then as part of my role as director of the Nutrition and Obesity Policy Research and Evaluation Network, or NOPRIN, I want to call attention to how we were able to sort of turn this work into something that that was actually useful to state and local implementers and how they could do their work better. If you are interested in how we can best help state and local implementers as researchers to move the stuff that sits behind firewalls actually into action on the ground that can help people, please consider signing up for NOPRIN, and you can see the website and our email address there. Next slide, please. So one of the things that I was noticing as an early clinical provider, as a general internist in the safety net setting, was that my patients who were experiencing food insecurity were having a particularly difficult time with diabetes management. And that was because there were cycles in availability of food within the household that meant that their behaviors changed across in many cases the month in a way that would have a different impact on their blood sugar. So for example, at the end of the month when food or money for food often had run out, there was much more likely to be episodes of skipping meals or reducing caloric intake, which would predispose these patients to low blood sugar or hypoglycemia if they were taking diabetes medication. And during episodes of food adequacy in the household, these patients were also more likely to avoid food waste, to systematically overconsume in anticipation of future episodes of food shortage, or shift to energy-dense foods, all of which are coping behaviors that could predispose people with diabetes to hyperglycemia or high blood sugar. And this wasn't just a pattern that I was observing as a primary care doctor. Next slide. You could also find evidence in the literature that there was a monthly cycle of community demand for food that really spoke to the fact that that episodes of food shortage were more common at the end of the month than the beginning of the month. And this research was coming from very different sectors, food banks and soup kitchens that, or free dining rooms, as we call them now, had very clear observations of needing to increase their support at the end of the month. There was evidence in the literature that big box retailers would increase their inventory and their staffing at the beginning of the month because there was pent-up demand for food after these episodes of food inadequacy at the end of the month. Grocery store scanning receipts showed a decrease in food purchases at the end of the month and an increase at the beginning of the month. And finally, household data actually revealed that certain people in the household, particularly mothers, decreased their caloric, carbohydrate, vitamin, fruit, and vegetable intake over the course of the month to accommodate these cycles. Next slide. And so my question, next slide, was whether these cycles had an impact on rates of low blood sugar among people with diabetes. And the way that we were able to look at this question was by looking at the date of the month that people were admitted to the hospital for a diagnosis of low blood sugar across all the states in California over an 11-year period. And what you can see in this graph here is the date of the month in the green line that every single hospital admission to an accredited California hospital happened during the time period. And you can see it's relatively flat over the entire month. That's the green line. And what you can see in the red line is those people who lived in the lowest income areas of California. And what you can see is that at the end of the month, there's a 27% increase in hospital admissions for low blood sugar events. Next slide. And we compared this to a counterfactual, which we chose to be appendicitis, to convince ourselves that this wasn't some artifact of the data and that other conditions didn't show a similar pattern. And this really suggested to us that food insecurity was an important driver of health outcomes, and in particular, acute health outcomes. Next slide. And so our next question was, how could we investigate whether that relationship was caused by food insecurity and amenable to treatment with SNAP, the Supplemental Nutrition Assistance Program? Because you could imagine if this relationship was caused by food insecurity, then a policy that is proven to reduce food insecurity by 20 to 30% should have an impact on this 27% increase in hypoglycemia admissions at the end of the month. Next slide. And so to do this, again, we were able to look for a pattern in the data, and this time do a more traditional natural experiment. And this was taking advantage of the temporary but quite substantial increase in SNAP benefits that occurred with the American Recovery and Reinvestment Act from May of 2009 to October of 2013. Next slide. And for this next study, what we did was we repeated the analysis of hypoglycemia admissions to hospitals and emergency departments, this time among commercially insured adults aged 19 to 64. So we were using a different data set to validate our results. And this time we looked at the odds of low blood sugar in the last week of the month compared to the first week of the month. And what you can see on those forest plots on the right was that we did see the end of the month increase in hypoglycemia in lower income households only, with this time a 7% increase in the odds of a hospital or emergency department admission. But we saw that increase only during the time when the economic stimulus did not exist. And it was not as clear during the period of the economic stimulus, although you can see that the tails, the confidence intervals of that are pretty wide. Next. And so what this suggested to us is that SNAP may have been having an impact, that SNAP may have been able to mitigate that increase in hypoglycemia at the end of the month. Now, obviously, this is not the perfect study. Next slide. And I really bring it up to reinforce the fact that we have lots of natural experiments right now and data coming out to help us think about them. And COVID really created a lot of those. This study could be done better and with additional stimulus periods that could increase our power. And we are just waiting for people to do those studies to further investigate the extent to which SNAP and other policies can reduce the impact of some of these structural and systemic drivers of poor health. Next slide. So this increase in end of the month hypoglycemia and the shifting in costs that it created from purchases of food to the consequences of that in the healthcare sector drove us to try to examine what are the excess healthcare expenditures that we think might be associated with food insecurity in the US. And in this study, we looked prospectively at healthcare expenditures in the 2 years after people participated in the National Health Interview Survey and reported on whether their household was experiencing food insecurity. And what you can see after we matched households as well as possible was that living in a food insecure household was associated with about an $1,800 increase in healthcare expenditures over the next 2 years. Next slide. And when we just did a back of the envelope calculation, adding up the $1,800 per year for adults living in food insecure households by the number of adults who are food insecure, we came up with this enormous number of $77.5 billion in healthcare expenditures annually that may be attributable to food insecurity. Next slide. So we got a ton of requests to help move that data into state and local estimates. How much is this? Are these annual healthcare expenditures associated with food insecurity in my state, in my county, in my community? And it took us a really long time to figure out how we would be able to come up with those estimates. And as a matter of fact, I told many, many people that we couldn't get that data didn't exist. But ultimately, we figured out a strategy to do that required the merging of 4 different data sets. So we're introducing a lot of complexity here, but I do think it's really important to think about how we can get directional information about this that can help state and local health departments understand the burden of these things in their communities. So in this case, we used food insecurity screening from the National Health Interview Survey. We used subsequent healthcare expenditures from the Medical Expenditure Panel Survey. We combined that with estimates of local healthcare costs created from the Dartmouth Atlas Project and merged that with data that estimated food insecurity rates at the state and county level from Feeding America's Map the Meal Gap. Next slide. And what we were able to generate from that was these really beautiful maps and some associated Excel spreadsheets that allow you to download from your own state and county what are the healthcare costs associated with food insecurity. And these are not always the patterns that you would expect because of differences not only in food insecurity rates, but also in the cost of healthcare in different communities. Next slide. So my take-home points from this work is if you have a difficult question to answer, natural experiments are often a really good first step, especially when you're thinking about social drivers. And we tend to think of these natural experiments just as these big shocks to the system or big policy implementations, but sometimes there are smaller patterns in the data that you can exploit to do some other innovative natural experiment work. And keep in mind that state and local implementers really need to move this research into their communities. And so anything we can do as researchers to support that work can be really helpful. Thanks very much.
Thank you, Hilary, for the excellent presentation. So now we'll transition to discussion and Q&A, which I'm really excited for a robust conversation. So just by way of recap, as I mentioned at the beginning of the session, I mentioned that all three of the panelists taken together have done an excellent job of covering all four quadrants of the Getting to Equity framework designed by Dr. Kumaniga, including topics which we may think about or may study less commonly in this space, includes social drivers like public housing, gentrification, development of transit systems, as well as food insecurity and federal policies like SNAP. But in terms of, or beyond this, in terms of methodological considerations, I noticed these two themes, which I'm really excited to explore further. One, that natural experiments with which everyone is leveraging across the board are absolutely a viable and rigorous way to understand or better understand the cumulative effects of PSE strategies like housing and transit development, as well as food policies on health inequities, including but not limited to child obesity, because as folks noticed, child obesity was not the sort of focused outcome of multiple presentations in this panel. And then the second point is these three presentations have made it clear that increased use of community-based, community-led, and stakeholder-led natural experiments exploring these social drivers are warranted and an exciting path forward. So I want to dig into these topics a bit more. My first question is for the full panel, and it's focused on measurement, actually. So yesterday we talked a lot about measurement of social drivers, covering topics like equity and healthy lifestyles, process measures perhaps that point to systems change, rapport building, humility, trustworthiness, and service, as well as unintended consequences. So whomever wants to start, but I was curious and wanting to provide space for folks to elaborate on the non-child obesity related outcomes and measures that they've been able to embed in their work.
I'll just reflect on that just to get us started. It's a really good question. And I think one of the reasons for this observation is that the further upstream we get, the more challenging it is to see the impact of our policies on childhood obesity. And it takes a long time to do that. And it's very difficult to detect. But we understand so much about the factors that sit between these upstream systems and structures and policies and childhood obesity that it becomes so convenient to look at those midstream factors as our outcomes. I think as a community of researchers, it's important that we wrestle with this more and allow those midstream outcomes to serve as proxies for childhood obesity sometimes, because it's so challenging to draw the arrows that go all the way from many of our policies to childhood obesity.
Thank you, Hilary. Do others have thoughts on this?
I think, as I mentioned in my presentation, that we were very intentional in like sort of drawing a broad swath of potential social drivers and looking at families as multi-generational units and looking at parents and children together to kind of really put all the pieces together to see, where is the change? Or even if there is no change, why is there no change happening in the outcomes we're interested in, right? And a lot of times these change will take a long time to occur. So we need to be measuring things that will sort of change more in the short term so that they offer some insight into what these potential pathways would be.
Great. So I also have a few specific questions for specific speakers. Hilary, you mentioned you had a great slide of sort of suggesting that folks look at sort of COVID-related economic packages next. And so I wanted to create space for you to elaborate that in terms of low-hanging fruit. And just for context for folks that may not have followed those policies, how did these COVID-related policies differ from the American Recovery and Reinvestment Act to the ones that you presented and evaluated in today's presentation? And are there primary research questions that you had in mind? Like, where would you start? Where would you recommend that folks start?
Yeah, I think there's lots of opportunity for innovation there, but just as a reminder, because we all, lived through this, there are a number of economic stimuluses that came that were provided to people through COVID. There were changes in school environments. There was changes in unemployment. There were changes in the way that people signed up for benefits, and all of these perturbations of the ways that our social safety net systems work, the ways we brought income into households, all of these, I think, can be exploited to better understand some of these upstream drivers of childhood obesity risk. They're hard to do because it's challenging to find control group, but I do think that we have to really wrestle with how we can do that well in order to take advantage of all of the interesting innovation that happened during the COVID time period.
Thank you for that, Hilary. My next question is for Dr. Roberts. Dr. Roberts, in your talk, you shared this fantastic slide citing several issues that the field may face, specifically in progressing equity-focused PSE evaluations like trust. You also sort of talked a lot about what you and your team did around addressing language barriers and just sort of meeting folks where they are in terms of bus stops. So I was wondering if you could elaborate a little bit more on how you see CBPR more broadly getting us over some of these challenges with equity in the way that we approach these evaluations, which ones remain, and how have you been able to approach building trustworthiness in your community?
Yeah, that's a really good question. Thank you for that one. I think one of the things also too, which I also kind of failed to mention, in addition to the timeline for this type of natural experiment, or, I think I can't remember the new word that you're trying to use at NIH. They don't really like natural experiments. But in any case, the whole ideal of this experiment is not only the timeline, but also the whole ideal of the timeline in the sense of the bulk of time you need to develop trust. Like it's not a very clear or not a very easy kind of set, like, oh, you just go out and get your participants. You have to really cultivate those relationships and cultivate them to be sustaining, so that you don't appear to just be in this fly-in by night type of researcher. And that's just really not really afforded in a lot of the grant type of timelines, in the sense that, when's the paper coming out? When's this? Or your quote unquote deliverables are not presented, where you I've actually spent a whole year and a half just going to meet these people in community centers, offering them things that they may need that may not even be anything related to the research. They may say, oh, could you do like a seminar on COVID? We don't know anything about COVID. And because they don't know anybody, they want to speak to a researcher. So you kind of have to foster those kind of relationships. And that's not something that is within the structure of a lot of grant infrastructures. And so I think for me, I've had to just learn how to piecemeal with getting funding here, and there, or, intramural, so that I can really have a genuine type of relationship, and one that's authentic with the communities. Because anytime that relationship is strained or bruised, it not only is that's not only a loss for that community, but other researchers who might want to come in that community later on, they will have that collective memory, like, oh, well, Dr. Roberts was here and she did X, Y, Z. So those are things that I really need to be considered by funders, if they are interested in funding this type of research.
Absolutely. I can totally relate to that, as doing some similar work around neighborhood development and food swamps in the North Hartford Promise Zone in Connecticut. I would love to hear from Dr. Datar if you would like to join in here. Your presentation actually initially inspired me to, or made me wonder more about your approach to or your experiences with leveraging sort of the unique uncertainty of trying to leverage housing redevelopment as a natural experiment. There's a bit of an additional or uniqueness to it, even beyond policy evaluation, I would say. And I wanted to sort of just create space for anyone to chime in here, please, Dr. Tar, but also anyone else who would like to share sort of their thoughts around how this sort of coupling of community-led or stakeholder-led natural experiments and evaluations of these social drivers are, present unique methodological challenges, maybe ones that you guys have not already highlighted so far.
Yeah, I think one of the sort of first challenges that I ran into was, I was wearing my researcher hat and I walked in there, 6 years ago, and I was like, oh, we're gonna be like flies on the wall, and this is a natural experiment, so we are not making the intervention, right? We're going to observe an intervention that's sort of happening naturally, and we're going to document what changes we see. And people were like, well, you're gonna document, and how's that gonna help us? And how, so it was like, we had some resistance in the beginning, and I quickly learned that, okay, yes, you cannot go in with that researcher mindset, because we were just, fascinated with like, oh my gosh, there's going to be $1 billion investment in this community, and we really need to study it. And my gosh, we can say so many things about it. And people were like, no, that's not how it works. So we really had to sort of take off that researcher hat, get into the community engagement piece, which meant like just showing up there for community meetings, your backyard barbecues, and talking to people about what we do. We met so many like kids in the neighborhood who were like, oh, you're from USC, you're doing this research, like how can we get involved? And we're like, okay, maybe you want to help us with some of our data collection work. And so we kind of brought them on board with doing some of our research. And that slowly, like first year was harder, and people were like, why do you want this data? And we had all these grand plans. We're going to put Fitbits on people. We're going to have accelerometers. And people were like, no, you're not putting anything like that on me. I don't want to be tracked, right? And in fact, we called them, it was funny, a funny story, we called them activity trackers. And people were like, no, we're not going to wear activity trackers. So again, we came in with this research language and research kind of way of doing things. And we quickly realized that's not how it works in community settings, and we had to learn. But it's been such a rewarding process to do that over the years, and see that people are getting engaged, and now they want to participate. And in the most recent wave, in our fourth wave, we asked people, would you give us like saliva samples for biomarker data collection? And over 80% of them said yes. So, to us, like over a 4 or 5 year period, they were like, okay, and because we kind of told them a little bit about what research we were doing. We were preparing infographics for them to show them, this is what we've learned about your community and the research we've done. I think all those pieces put together really helped build that sense of trust in community and involvement.
Absolutely. And building that trustworthiness, as well, as folks talked about in day one of Opus 2 yesterday. Do Hilary or Jennifer, would either of you guys like to comment on this question? Okay, so I'm going to go next to some questions in the chat. So there's some interest in data access. So one question is, could the speakers comment on data access when you use existing or administrative data? Is this a barrier? Are there data resources exist but can't access? So please, anyone that'd like to start.
I'll say it's often a challenge in the work that I do, particularly in terms of linking data sets, and it's for good reason, and we have to make sure that we're protecting our communities. But I do sometimes think that issues of data access are limiting our capacity to understand the impacts of our policies, because we're not able to link administrative data about the policy in some cases with downstream data about what's happening in for example, health outcomes. So I think these are big structural challenges that that could, if they were mitigated, help really accelerate the policy research we're able to do.
I haven't really had any barriers per se in terms of data, because it's been primary data that I've collected, but the barriers that I have had have been, for example, in the study that I was just talking about, we used a panel survey. And so some of the barriers that we had were actually being able to really more definely geo or locate the residents because of privacy issues. So we've had to kind of be creative to go a little bit broader in terms of being able to not necessarily have the address of the individual, but maybe having the closest intersection. So that's probably the biggest challenge that I've had so far. But so far, it really has been more of just accessing the participants more so than the actual data.
Absolutely. I can, as a neighborhood researcher myself with Black and brown populations that have higher proportions of immigrants and don't trust government and tracking and things like that. And even university, right, as organizations, they don't trust us either in a lot of cases. That is absolutely a challenge. The last question that I'll share from the chat to wrap us up for this session is specifically to you, Hilary. It says, could Dr. Seligman explain more about whether the 77.5 billion comes from food insecurity or all the other stressful correlates of poverty that are associated with food insecurity? In other words, does she think that the analytical methods use control for this multicollinearity?
So the answer to the question is we did the best we could, and it's not perfect. And one thing that I hope people on this call are thinking about is how can we do this better in the future? In terms of the actual methodology, we limited the sample within NHIS to people who are less than, I think, 200% of the federal poverty line, and put in as many covariates as we could to try to control for the other markers or correlates of poverty. But we definitely didn't do a perfect job at that. And there's going to be messiness in this kind of data. It is the best we have right now.
Thank you, Hilary. And with 1 minute to spare, there was a part 2 to this question, actually. The question reads, in your example where you merged the 4 data sets, this is for Hilary, did you develop model-based estimates using the 4 data sets, given that some of the data are not state representative, but rather nationally representative?
So this is exactly the reason why I said over and over that these estimates couldn't be created, even though there was such demand for them. The NHIS numbers, the 1,863, is not a state-based estimate. That is for NHIS overall. Map the Meal Gap and the Dartmouth Health Atlas allowed us to get state and county level data, and that is what we use to adjust for community level indicators.
Thank you, Hilary. So by way of wrapping up for this session, thanks to all 3 of you for wonderful presentations. I learned so much. I enjoyed the conversation. It's nice to be with like-minded, equity-minded folks, having these tough conversations. And I'd like to also thank INCOR for the opportunity to moderate this session as well. Thank you so much. I think I'm passing it back to you, Dan.